Ready?
You're ready.
All right, awesome. All right, so welcome back to another week of inspiring critical care lectures. Today we're having a few change in things for ultrasound. I'll go ahead and do the ultrasound lecture. It's part of our Hocus Pocus series. It's primarily focused on prep for echo boards, which will, primarily focus on cardiac stuff. But, the echo boards, they do now, I looked at the blueprint, they do have stuff from other systems. So they're trying to make it more critical care boards. So they are looking at lung ultrasound, right upper quadrant ultrasound. Um, and so we'll try and focus on some of that stuff, but primarily the series will be focused on echo stuff, which the attendings will do. And then the second hour will be a lecture on LVADs. Jared unfortunately had to work overnight, so the choice was between an Impella lecture, another Harvey lecture, or LVADs. We'll do LVADs since we do have a patient down in Vineland. And then after that will be our hands-on ultrasound. Joanna, you're with Dr. Baldwin in Malika Hill, is that correct?
Yeah.
Awesome. So then you guys can, find a patient with pneumonia and atelectasis over there, and then Dr. Hussein will help out the fellows down in Vineland. And really the goal for that series is kind of, we'll touch on it a little bit here, but is to really be able to differentiate and as to be able to identify pneumonia and characterize it on lung ultrasound, and then what type of things can you use, specifically linear atelectasis, dynamic air bronchograms, and color Doppler to differentiate it from atelectasis. And then if you guys have time, how to confirm ET2 placement after you intubate using ultrasound instead of waiting for the X-ray, both of which I'm sure they are really good at and knowledgeable on. So with that, to get started, so the question here is, how do you approach the dyspneic patient with ultrasound? Meaning the patient that's, you get the rapid call for shortness of breath, and how do you approach that patient using ultrasound? And it's really inspired by this book, Lung Ultrasound, The Critically Ill. If you guys would like it, I can send it out this week. It's not too long of a read, but it's really, I'll talk about the author in a bit. And so, if you guys have had specifically for the residents, the unfortunate scenario of, rounding with me or with being on with me overnight, then you know that anytime there's a rapid response or a code, I kindly request that you guys, instead of going straight to the rapid response or code, first head to the ICU, grab on that floor, grab the ultrasound machine, and then head over to that patient, because we'll almost ultrasound everyone. And if there's any, scenario where the rapid response was called for hypoxia, for hypercarbia, for respiratory distress, for work of breathing, then, of course, we're going to be ultrasounding them, because I simply do not want to wait for the X-ray. And I'll explain why. So you get a call for a 56-year-old female who's, came to the hospital for cough, shortness of breath. She's located in the far away country of 2 East. She was initially stable on 2 liters. They haven't been able to come up with a diagnosis because the X-ray just shows gunk. And so they think it's CHF and pneumonia and COPD. So she's getting all the things. And now she's, slowly going up on 4 liters. And then a rapid response gets called around 2 a.m. for respiratory distress. You arrive, she's working to breathe. She's on 6 liters and a non-rebreather. And so, what do you do in this scenario, right? You do your whole ABCs, right? And we all know how to kind of approach this, ABCs, IVO2 monitor. So she's being able to speak to you, but she is hypoxic, low down to the 80s on room air. So you quickly put all that oxygen back on. She's not examining in shock, meaning that I don't care about the blood pressure, but her cap refill is good. Her extremities are warm. And so one way to approach this would be, all right, let me grab that stethoscope and listen to her breath sounds. And, I don't know what that sounds like because I haven't carried a stethoscope in almost 2 years. But, she's got decreased breath sounds on the right side compared to the left. And then you say, okay, let me get a chest x-ray. And then you obviously hear the response, okay, I'll go ahead and put the order in. And then you say, no, go ahead and please call. And then you hear, okay, I'll go ahead and call. And the chest x-ray tech says, I'll be up soon. Meanwhile, you don't have a diagnosis. You don't know what's going on. So what are your differentials in this case? Well, they're still broad as broad. So you can think about, I think things that probably all of you are thinking of right away is someone who's got really bad pulmonary edema from fluid overload. Maybe they have a PE given their work of breathing and their tachypnea. Maybe they already have existing lung disease because someone in the chart says they've been in and out of the hospital for pulmonary symptoms. Maybe this is an asthma or COPD attack. Maybe they have a pneumothorax, or maybe they have pneumonia. So really your P's, minus the COPD and asthma. And these are kind of the differentials that quickly come to the top of my head. Yes, obviously there's a whole list of more unicorns and zebras, but this will probably cover 90 to 95% of what's causing this patient to be so sick. And so, really going back, this is not meant to be a lecture, but, credit is due where it's due. In 1816 you guys know who made the first stethoscope? Bit of history. Well, it's René Laennec out in France. And what he really did was something as simple as he just took a long paper tube, rolled it, and then used it to funnel the sound from a patient's chest to his ear. And then, fine, we're getting a little more advancements in our immediate bedside diagnostics. Around 1895, a gentleman by the name of Wilhelm Röntgen in Würzburg, Bavaria, discovered X-rays while testing whether these X-rays could pass through glass. And then fast forward, 1953, Inge Helder was the first guy to engineer to be able to perform an echocardiogram using a control device. And then, really ultrasound advanced, not because of, critical care or emergency medicine, but because of, in the 1950s, an OB physician, Ian Dold, and an engineer named Tom Brown started using ultrasound. And then they realized that right away that, hey, look, the advancements here are not just for OB, but for lung ultrasound as well. And so this is the patient that you guys have. So, just kind of looking, what do you guys see on the chest X-ray? So ignore everything else and just purely focus on the chest X-ray.
Effusions left.
Sorry?
Pleural effusions left. Light trace, maybe some bilateral or right side as well, trace. And can't see too much else.
Right. That sounds like Sanjay, is that correct?
Yeah.
Hey, man. Yeah, so absolutely could be, right? So you're saying that maybe there's, loss of the left hemidiaphragm, that clear delineation. So maybe you're concerned that this is a pleural effusion. And so you're thinking, okay, maybe I need to start diuresing this patient. Maybe I need to start putting this patient on BiPAP. Anyone else? Sorry?
Right lower lobe looks like stuff.
You're saying this right here?
Yeah.
It looks like what?
Also,
Trace.
around the cardiac
Yeah.
center on the right side as well. I don't know if it's like a little bit of opacity there. It doesn't look as smooth, but we would need a tube view to see
You're thinking right here?
that too, but also on the right side on the right cardiac border. Yeah.
Yeah, absolutely, right? So these are all things that, you guys are masters now in reading chest X-rays, and then for the ER residents, the IM residents, and the TY residents, and the surgery residents, you guys will all obviously become masters at this as well. Maybe not the ortho residents, but that's okay. And so, absolutely, right? These are all things that you're kind of delineating. Is it, CHF exacerbation? Is it pneumonia? Like, there's this little hazy infiltrate right here. And so in this rapid response, I don't think anyone here confidently has a clear diagnosis, and I think they're going to be giving antibiotics and diuresing, in my opinion, unless, you guys feel strongly otherwise. So then, maybe some of you guys will say, let me go ahead and get a CT. But you know what? I don't want to go ahead and wait for that. I want to know now. And so this is an actual case. The patient was diagnosed with pneumonia by bedside lung ultrasound. And what you're really seeing is that the patient does have bilateral pleural effusions, which is more significant on the right side. That right lower lung lobe was consolidated. And what you're seeing here is you're seeing, and I'll get to what these signs are, so it's not a foreign language, but it's a quad sinusoid sign, and then you can see what we call a shred sign. And then, on this chest X-ray, given what I'm seeing on this lung ultrasound, which to me are pretty severe symptoms, the chest X-ray relatively looks pretty benign. And so CT was done once the patient was stabilized, and you could see a pretty prominent consolidation in the right lower lobe with bilateral pleural effusions. And you can even, what they did was that they saw some sediment in the bilateral pleural effusions concerning for a parapneumonic effusion. And so going forward, like you have Dr. Lickenstein, who is basically the father of lung ultrasound and the author of the book I mentioned. He's published some great papers in chest because of his work. He's really inspired a lot of advancements in how to use lung ultrasound, primarily in emergency medicine literature, but has now been applied to critical care, internal medicine, etc. There are a few other protocols out there, but there's just more data on this one. And personally, I find this one very easy to use. There's like protocols for trauma exams, for post-intubation exams. But really, I find this one really good for that, for kind of like half of our RAC calls, right? There's hypotension and then there's shortness of breath. And so how do you approach the dyspneic patient? The one thing I will say to this exam is that it does not involve a good cardiac echo exam, which I would still recommend doing, at least a focused one in the dyspneic patient. And so if anyone hasn't seen the Blue protocol before, it's this little diagram. This was the picture that was published in the paper. It looks complex, but honestly, it's really just asking for two or three questions, and then it's easy. And your exam really only requires, you'll have your answer, 60% of your answer in the first minute by just looking at the anterior side of the first half. And you don't even have to get to the PLAPS points, which is those posterior points, which I'll show you guys in a second. And so it's called the Blue protocol, bedside lung ultrasound in emergency. And how does the data on this specific protocol compare to a chest X-ray or a physical exam? And honestly, it does a really nice job. The data shows that it is actually more sensitive and specific than a chest X-ray and far more better than a physical exam. And specifically for the diagnoses that we talked about, pulmonary edema, COPD, asthma, not as high for those two, but for pulmonary PEs, kind of there, but the data is really the best for pneumonias. And so, when you look at the Blue protocol for pneumonias, you can see that when looking at specific findings, you're reaching a specificity of almost 100%. And then the sensitivity, when you look at, when you look at all four profiles, when you complete the entire Blue protocol, your sensitivity is pretty darn high. And so all this to simply say is that the data is good, and always, kind of be very cautious about when you're looking at these protocols or picking up a specific type of exam. It's just how sensitive and specific is it, and what's the positive predictive value for that specific type of test. So, you don't have to use the linear probe. It is the recommended one because you really want to try and get close to that initial part of the Blue protocol to use the linear exam, to do the linear exam. But really, you can also use the phased array as well. And for those of you guys on the internal medicine floor, you don't need a big ultrasound to do all this. The butterflies that you guys have are honestly great for this. So when you guys respond to a rapid response, a few of the residents and I used to take the butterflies that you guys have and take it to every rapid response so we could, ultrasound everyone and just kind of get that practice in to make a diagnosis before the fellow would. And so where do you look? So there are 6 points that you guys should be looking at, 3 on each side. And, this was very standardized when they did the research studies, but obviously there's going to be a good amount of variation based on body habitus. And then obviously other things come up, like, maybe there's hardware in between and things like that. But in theory, and you'll kind of reach the same point every time as you do this more and more often, is that you take that mid-clavicular line, and then you kind of just go downwards. You put your hands, your fingers at the sternum, and then right where your fingers meet your palm is where at that mid-clavicular line, at the top and at the bottom is going to be your anterior points, your anterior blue points on the left side and the right side. And there's a superior and an inferior. So there's upper blue, lower blue on the left and the right. Then you take the nipple line, and then you go backwards along to where that trapezius muscle is. And then you put your knuckles down, your wrist facing up, or your thumb facing up, and then point the probe towards the anterior chest from the back. So you can see that the probe is in the back, the wrists are against the bed. Sometimes you're able to get the patient to turn over a little bit. Majority of the times they'll already be sitting up because they're in respiratory distress. And then you point that probe towards the anterior side, really towards that nipple, and then you can get that posterior lateral alveolar and prognosis point, which is your PLAPS point for short. And so it's just these 6 points. And so once again, your anterior upper and lower blue points, and then you go along the axillary line to that phrenic line, and then that'll get your collapse points. That's the full name, posterior lateral and/or pleural syndrome. The mnemonic, I think that they used the paper was knuckles down and shoot for the sky. And then obviously continue to reposition as you need to. And the way I approach it is I do my 4 anterior points first, and then I do usually my right side first and my left side. You can really consider that collapse points like the Morrison's pouch for the lung. So, to kind of understand how all this works, a little bit of basics, not too much, but really the idea of ultrasound semiology is that you're really trying to find something that may indicate something else. You don't actually see a pneumonia on ultrasound. You don't actually see pulmonary edema or a PE on ultrasound. You're using these concurrent findings, this pattern recognition, to recognize that something else is either there or not there. And so a little bit of physics, I apologize. When you're doing that first, answering that first questions, the first question that you guys answered as part of the blue protocol is there lung sliding? And you look at your anterior points to do this. And so you'll take your 4 points. Some protocols recommend 6, some protocols go as far as 8. If you're specifically looking for a pneumothorax, you may go ahead and do more than just the 4, but usually that 4 is adequate. And what you do is you're saying, is there lung sliding? So what am I saying by is there lung sliding? Is I'm taking my probe, usually that linear one, or the phased array, so I can fit it between the 2 ribs. And you take that, you find your bone. So what you're seeing is that this shadowing right here is bone, right? Because it's very hypoechoic, meaning that the ultrasound rays are not being able to pass through all that thick calcium, and so you're seeing nothing behind it. And then what you're really looking for is that hyperechoic shimmering line under the subcutaneous tissue. So this is your subcutaneous tissue, and this right here is that hyperechoic shimmering line, which is your lung sliding between your parietal and your visceral pleura. That shimmering is normal. Once again, there's your visceral pleura. Sorry, there's your parietal pleura, and there's your visceral pleura. And there's those 2 things as the patient is taking a breath are sliding against each other, and you get this like shimmering, or like, some people call it like ants on a log sign. And so what do you guys notice here?
No long sliding.
Yeah, there's no shimmering, right? And so this could mean, I'm not saying it is a pneumothorax, it could be a pneumothorax. We'll get to that in a second. Lack of lung sliding does not always mean pneumothorax. Once again, lack of lung sliding does not always mean pneumothorax. And so, look at this patient, right? This patient obviously has a collapsed lung, and what you can actually see is what we call a lung point. So this is the point at which the patient is taking a breath, and as they're taking a breath, are you guys being able to see the image move?
Yeah.
But yeah, I just want to make sure because there's a lot of GIFs in here. So if you guys aren't seeing those GIFs, please let me know, because that kind of ruins the entire PowerPoint. So you can see, right? Like, so you keep your point focused between these 2 ribs. Imagine a rib here and a rib here, and you're in between 2 ribs. You're not seeing anything here. You're not seeing anything here. And then you're just focused on this point. You zoom in all the way to see that thick hyperechoic line, which is why I really like the linear probe for this. And then you see that, okay, you know what? I'm seeing initially, if you can even slow this down by recording it, you can see that there's lung sliding, and then there's lack of lung sliding. It changes in and out. So you found the lung point, the point at which the pneumothorax enters the plane of the lung enters the plane of view to where it collapses, and then you no longer have sliding between the visceral and parietal pleura. So, once again, there are a lot of false positives behind why lung sliding would be there, meaning that there is lung sliding. However, it's not a pneumothorax. And so what are other differentials that could be causing it? Well, someone who has had a cardiac arrest, right? Someone who's completely apneic, right? They're no longer moving between the visceral and parietal pleura. So that could be a cause of lack of lung sliding. Someone who has profound atelectasis, right? That alveoli has completely collapsed, so you're not going to have that. I go ahead and intubate, and I go ahead and just completely right main stem, or somehow I intubated the esophagus, and now they're paralyzed. They're not, having any respiratory movement. You're going to see that on the side where the tube went down the trachea, or the main, if you say went down the right main bronchus, you're going to see a lack of lung sliding on the right side. Or if the patient has really bad bullae, or from like from a really severe emphysema, your really bad ARDS patients where that lung has become fibrotic, some of those patients that from maybe a pleurodesis, they damage the phrenic nerve. Maybe they've had a prior pneumonectomy, or really they're just so deconditioned that their inspiratory effort is pretty much gone. And so really what's happening is that these patients will present with a lack of lung sliding, and the question is, how do I differentiate these differentials from a pneumothorax? And so there are a few ways to do it, and that's where really M mode comes in, because in these patients, you might see some micro movement. And so even, and this trick I love, and I'm sure you guys already use it, even if you don't have the consideration of other differentials, because sometimes it can just be hard to see that ants in a log pattern. And it's you put the M mode, which is motion, down those where you think that hyperechoic line is, and then see the pattern. And if it's nice and shimmery, like the seashore, then that lung sliding is there. If it's not, then it's that barcode sign. But even then, it's really not enough. And so I'll get to that in a second, but this is that lung point I talked about. So if you put M mode to find that lung point, this is what you'll see, is that you'll see, okay, you know what, they're shimmering, and then there's not shimmering. So it's like you're going in and out of that lung point, that diagram that you guys saw earlier where the patient's taking a breath and the lungs coming in and out of the view from where it collapses. That's your lung point. And so we talked about, right, like how do you differentiate other things? So what are some other false positives? Well, one way to differentiate is the presence of A lines. If you see these lines right here, you see that little line that's kind of showing up? I kind of drew over it. But if you see that, can't delete it. If you see, yeah, there it is. If you see that little, these lines like this, then this patient has lung sliding over there. And so if you see A lines, that means that, if you see these A lines, then they likely have a pneumothorax. If they don't, then it's probably a false lung point, because you should really see it there in the setting of a pneumothorax, because it's really that, I'll explain what A lines are in a second, but that artifact should be there. And then other things that you might just be somewhere else. So for example, like, this interface right here, right? No lung sliding, right? That's a classic ants in a log. And so right here, the patient, you've put the probe at where the diaphragm comes across the chest on the anterior side. And that's why here you see lung sliding and here you don't. It's not to mean that, this area right here is a pneumothorax and then you actually go in and place in a chest tube. And so another one to know is a lung pulse, which can also help you rule it out. And so what that is that, and this is a concept that can be kind of tricky, took me a while to understand. And so in this picture, you're seeing no lung sliding, right? But under that, so you see that, you're not seeing that ants and log pattern. You put the M mode on here, you're not seeing movement, but then you see all this movement over here, right? And so you're seeing deeper artifacts between the visceral, you're seeing deeper artifacts under the pleura, which, I think the simple mantra when you guys approach ultrasound is that fluid is your friend and air is your enemy. Once again, fluid is your friend, air is your enemy. And so when you have air between your visceral and parietal pleura, you really shouldn't see much. The only thing you should really see are some A lines. And I'll explain that in a second, but if you're seeing a bunch of stuff underneath, that means that the pleura are together. There's that maintained connection between the visceral and parietal pleura. There's just limited sliding with the respiration, and you're able to see all this stuff underneath. And that's what, any idea what this is? So what you're seeing is basically reflections of cardiac pulsations of the heartbeat. And if you're able to see that under a region where you have lack of lung sliding, that means there is definitely no pneumothorax, because you should not see cardiac pulsations. And it can actually be very specific for a particular diagnosis, which is atelectasis. And there's a few papers to show that, that when you find that lung pulse, specifically at the left lower blue point, that visualized cardiac pulsations under a region where you do not have lung sliding is classic for atelectasis. And that should make sense, because your visceral and parietal pleura are still connected together. meaning that because they're connected together, you can see things underneath. There's no big gap of air like a pneumothorax to not see the cardiac pulsations underneath. And you'll see those with respiratory variations as well. And so you can also use that, primarily like next time you accidentally think you have a patient who you right main stem, you've called the respiratory to come and retract the tube, quickly go grab the ultrasound, take a look at that region where you right main stem, and you'll see really profound atelectasis, maybe not too early after if you just right main stemmed. Sorry, not on the left side, you'll put the probe on the left side, you'll see that there's atelectasis there because you're not ventilating that left side. And you'll still be able to see the cardiac pulsations under a region where there's no lung sliding. Any questions on the lung pulse? Cool. All right, so like I said, first question you're asking as part of the Blue protocol is there lung sliding or not? And then, they can kind of be, when you look at like trying to differentiate, some pulmonary edema, say like, in another region of the lung, you see that there's pulmonary edema. And then in this region, there's not. You can actually help characterize pneumonias as whether it's like, like a benign or a more like, severe pneumonia. You can see that in patients that have lung sliding, the diagnosis may be pulmonary edema, PE, COPD, or asthma. But in patients that don't, it could be a pneumothorax, or it could also be a really bad pneumonia that's causing it. Oops. And so, when looking at the data for a pneumothorax, it's really good for the trauma population, and that's where they really study the lack of lung sliding. It's not as good in the critically ill patient because of all these other differentials that we talked about. And the biggest one I see is atelectasis. And so you can see that, in this specific study done in the ICU or in critically ill patients that are not for trauma, that, like 109 patients, 47 cases had no lung sliding. It did not mean that 47 patients had a pneumothorax. They all checked multiple times that yes, this patient definitely did not have lung sliding, but it did not mean that they didn't have pneumothorax. They probably had atelectasis. And so, if you find your lung point, you're more able to make that diagnosis of a pneumothorax. And a lung point is almost 100% specific, once again, specific for a pneumothorax. And so this is once again that, oops. That lung point, right, where you see lung sliding on this left side and on the right side. You see lung sliding on this right side and it disappears. Use that ebb mode and find that lung point. That lung point, if you're able to find it, is 100% specific for a pneumothorax. So, question one: is there lung sliding? No, yes or no, and then you're going to try and characterize what you see a little deeper than that, and that's when I just increase the depth a little bit. Sometimes you don't have to, so I can see up to the level of 3 A lines. And so what are A lines? This is what I call Berlin space, or sorry, what Lichtenstein calls Berlin space. And what's really happening here is that you have your pleural line and the probe, and then you have your visceral pleura and your parietal pleura. And what happened is that as the long ultrasound rays go from there to this hyperechoic, this really hyperechoic pleural space, it'll hit the space and then reflect backwards. Some of those waves will get through. So right here, and then some of those waves will reflect backwards, and then some of those waves will get through. This distance between here and here will be equal to the distance between your probe and your rib space. And then it'll create this artifact. And that artifact is so thick that even then it'll reflect off that artifact, go back to the probe, and then, so you have all these waves that are going here. Some of those waves reflect backwards, and then it'll create a mirror of that reflection here. And then this will create a mirror of that reflection to here. And that's what these A lines are. And I usually want to see 3 A lines when I deepen my space. Any questions about A lines? So A lines could be a normal lung, but you could also see, if you don't have lung sliding, a pneumonia. That this could be indicative of not pneumonia, of a pneumothorax. And so the next one is B lines, right? We've got A lines, now what are B lines? These faint little, I don't know if you guys remember from like day one of med school when reading a chest x-ray, those curly B lines that you guys learned about, that could be indicative of CHF exacerbation. So what does that exactly mean? I really like this infographic by Core IM. So I don't know if you guys can see it, those curly B lines. And so what those curly B lines are, these that, we say is indicative of a CHF exacerbation, is that when you actually break down what's happening at like the, micro level at the alveolar space. So this is an alveoli. Around the alveoli, you have lymphatic drains and then blood vessel drains, creating this like hexagonal shape or this, this border around the alveoli. When you have edema, regardless of the cause, whether it's, I'll get to the cause in a second, but regardless of the long list of causes that could cause edema in the lungs, that thickening of fluid, once again, all fluid is ultrasound's best friend, causes these lines that you see on chest x-ray. It causes that B lines that you see on ultrasound. It's really just thickening of this interlobular septa. And then you see that, they're kind of parallel to each other, right? So here, they're parallel to each other in that shape. They can be perpendicular to the pleura line. So that's why they're kind of shaped this way. And they're very peripheral in contact with the pleura, and that's what you're really seeing. And so it's not just CHF exacerbation. It's not just pulmonary edema. It could be due to cancer because it's, the lymphatic drains are very thick, very full. It could be due to lymphoma. It could be due to lymphangicarcinomatosis. It could be due to a pneumonia, right? Because that's going to cause a lot of lymphatic drainage to sarcoid, all these other interstitial lung diseases. When you see B lines, the only thing that B lines tells you is not that it's a pulmonary edema. The only thing that B lines tells you is that it's not a pneumothorax. So once again, when you see B lines, the only thing that you can definitively say for sure is that there is no pneumothorax there. And I know a lot of people will see B lines and say, you know what, I want to go ahead and diurese this patient because there's pulmonary edema. But that's simply just not true. And we'll get to, why. And you can already see why, right? There's all these other differentials of what it could be. You could have a patient in shock from a really bad pneumonia that you're seeing a B-line pattern, but it's not edema. And so once again, the only thing that it tells you for sure is that it's not a pneumothorax in that specific region. This is what I was kind of saying, that area perpendicular. So here's your pleura. And then you'll see like thickening of the lymphatic drains here, whether it's pulmonary edema, cancer, malignancy, whatever, ARDS, whatever. And then you'll see those like hyperechoic glands. This point where you see the lymphatic drains converging is what causes these B lines. And so, the physiology is the same as if you ever go scuba diving and you see these like sun rays coming down, or in a really deep swimming pool, you see these rays coming down. It's the exact same thing. And you'll see these like shimmering rocket sphere lines, these rocket lines. And right, so if you look at again this diagram, this right here, that point where your lymphatic and vessel systems converge, that's what's creating this artifact of these B lines. It's pretty much an artifact, and it's, it was first discovered when they did studies to look at characterize A lines and B lines. So what they did was patients that were getting PA catheters, they saw that patients who had high pressures, like wedge pressors, and to try and characterize like pulmonary edema, that those who had a pattern of A lines only were dry, meaning they had, low CVPs, they had low pulmonary capillary wedge pressures, versus those that had B lines correlated with those with high CVPs or high pulmonary capillary wedge pressures, really characterizing what they call like alveolar interstitial syndrome, which is just a fancy way for saying that, those interstitial spaces with those blood vessels are full. You can characterize these B lines, don't just stop at B lines. Is it a comet tail pattern? Does it start at the pleural surface? How many B lines are there? Does it spread all the way down to the screen? So if you get those 3 A lines, does it go all the way down? Does it make your A lines disappear? And are they well-defined? Are they heterogeneous? Are they homogeneous? And these all characteristics matter because it'll help you to make your diagnosis. So, this is what the chest x-ray shows, right? Everyone here is expecting to see B lines, right? And so you see this, could it be ARDS? Could it be baseline, interstitial lung disease? Could it be a pneumonia, multifocal pneumonia, or could it be just really bad pulmonary edema that's just everywhere? And so this is where the characterization of your B lines will help you out. Like this is, you can kind of call it like B and B prime. So, the regular classic B lines that you hear are the ones with those like homogeneous B lines. All these B lines look the same. They go all the way down to those 3 A lines, like you cover your screen. They all look the same. There's more than 3. They all start at the pleural surface. You still see a clean pleural line. It's a clean straight line versus like this jagged, crappy, ugly looking appearance. And you're not seeing anything under the pleural space, just this lung sliding with B lines, versus contradict that with what we call the B prime pattern, or a non-hydrostatic pattern that's not indicative of pulmonary edema. You'll see all the B lines look different. There's maybe a lack of lung sliding. You see all this gunk. I think the best word that I can use is just gunk under the pleural surface. And it may not be going to everywhere, maybe just going to like some regions, like, when you do your blue points, maybe just 1 or 2 of the regions, not all 4 regions. So that's how you differentiate between B and B prime. And you can actually document that and kind of help say, because this is a B prime profile, meaning that there may be a lack of lung sliding or it's reduced, that is only in certain regions, it might be more indicative of a different diagnosis that's not pulmonary edema. Because pulmonary edema, right, if you have someone in heart failure exacerbation, should cover all 4 of your lung points. So just once again, differentiating your B lines. Would you guys say this diagram is B or B prime? Anyone? B or B prime? So I would go ahead and say that that's, just a regular B profile, because you see that you have this clean, straight, shimmery line of your, that connection between your visceral and your parietal pleura. You see straight, clean lines going all the way down. They all look the same. There's nothing under this pleural surface. So it's probably pulmonary edema. Now, contradict that with this one, right? You're not being able to get as good a view. You don't see that clear pleural space. There's all this gunk underneath. All your pleural lines look different. This is probably, I would say, B prime. And that's how I would characterize this. Say you get to your space between your ribs and you see this. How would you guys characterize this? Anyone? Just want to make sure you guys can still hear me.
Yeah, we can hear you. You just don't know what
Yeah.
we're looking at.
So, this is, that this is not a rib space. Some of you guys might accidentally say that this is a rib space, but the way you know it's not a rib space is because you can still see stuff underneath, right? If it was a rib space, you wouldn't be able to see anything underneath.
The atelectasis?
It could be, right? So this is what I would call a C profile. Is notice the C?
How many letters are we going to?
I'm really enjoying the red marker right now. So this is what I call a C profile. And can anyone guess what the C stands for? Consolidation. You can, this is almost, yes, it could be atelectasis, but remember we talked about that B prime profile. So it's really just like a spectrum of that. And what you're seeing is that you can maybe see some haziness lines, but this thing is so bad, this like irregularity, that it's just air trapped in that area. And when you have like air trapped in an area of a lung, you'll see this really in your anterior blue points. It's really indicative of pneumonia. And so once again, just to review, A lines, B lines, and remember there's a spectrum of B lines. There's B, B prime, sometimes you'll see A and B, and that's your C lines. And so just some more examples of what C lines look like. You guys can see that little pattern, this gunkiness. It's just, you're just destroying that pleural interface, right? And it's just gunk. And that's likely indicative of pneumonia.
Is that different than a dynamic air bronchogram?
Yeah, so we'll get to dynamic air bronchograms. Dynamic air bronchograms you'll see in your PLAPS points. Those posterior points that we talked about. This is, once again, we're still in your anterior blue points. And this is where you're seeing all that gunk. So you're kind of, yes, you're kind of looking at the same thing. But with your C profile, you're destroying that pleural interface, and that's what you're looking at. But the reason for it is the same as what causes air bronchograms. And so, once again, your blue protocol, as simple as it gets to, I'm going to try and speed things up a bit, is there lung sliding? And then when you see lung sliding or you don't see lung sliding, what do I see underneath that area? Is it an A profile or B profile? So imagine this as your dipstick patient. You take your ultrasound, you look at the 4 quadrants. This is right. This is left. This is upper. This is lower. So, you're doing the blue protocol. You're trying to make your diagnosis. You're coming up with your differentials. Question 1, is there lung sliding? Who wants to take a crack at this patient? This is who wants to respond to this rapid response and then put the probe on this patient, and this is what you get. Who wants to try and figure out what's going on?
And I see lung flying right there.
Yeah, and you see it in all 4 regions, right?
Yep.
Okay, so it's lung sliding. Now, is it an A profile or B profile?
B.
Yeah, because you see like these, and I wouldn't even say B prime, I would say more like a B profile, right? You see good lung sliding throughout. You see these straight, homogeneous, clear, demarcated rocket lines that go all the way down. Like this is textbook for what? What's your diagnosis?
Yeah. Pulmonary edema.
Yeah, I think my suspicion of pulmonary edema is pretty high because I have lung sliding, and I have homogeneous B lines everywhere in all 4 quadrants. So likely pulmonary edema, correct? And so, in between, as part of that protocol, it may not just be clear A line or B line. And if it's really hard to differentiate, it could also be an AB profile or C profile. If you see this AB profile or C profile, meaning that it's A in some regions, B in some other regions, I'm really thinking pneumonia. And so this is kind of like simplifying that algorithm. If you see an AB profile, meaning that you have A in some side and then B in some other sides, it could be pneumonia. It's not going to be pulmonary edema because pulmonary edema, especially cardiogenic, should be everywhere. And it's not going to be COPD or asthma because why would that be causing this B lines? This can obviously, it's very simplified, right? Patients, we talked about like Occam's razor versus Hickham's dictums, like patients are going to present with multiple findings, especially these critically ill patients. But you're really trying to simplify things. B profile is likely indicative of pulmonary edema. It could be pneumonia because you could have a multifocal pneumonia, which is where that B prime pattern comes in. If it's an A profile, it could be COPD or asthma, which is more like a diagnostic exclusion in lung ultrasound. It could be a PE, it could be a pneumonia that's just localized to the right lower quadrant or left lower quadrant, but you've nearly ruled out pulmonary edema. And so who wants to take a crack at this one? It's the same patient or a different patient, left side, right side, upper and lower. So question 1, is there lung sliding?
Yeah.
So do you see lung sliding?
Yeah.
On the right for sure. Below the right, I see it. Other one.
There's lung sliding in some areas, but not in all.
Yeah, so in this one there is, in the right upper there is, in the right lower there is. What about the left upper?
No.
Left lower does not, left upper,
It's hard to tell.
it's a little hard to tell for me.
Yeah, you kind of see this, right? You kind of see things underneath, right?
But that's the pulsation, right? It looks like cardiac pulsation.
Is it?
Yeah, so it's your lung pulse. So what do you think the diagnosis is in this patient? Because if I'm just doing this, I'm gonna be thinking about pneumothorax. I'm not 100% set on pneumothorax. I could be thinking about pneumothorax. But this, when I see this,
Pneumonia.
I don't know, right? And so I want to make sure, and what I probably want to do is I want to take an M mode and put it down here and see if I get that lung point. Is this pulsation, am I seeing a lung point? And in this patient, I put the M mode and you can see that there's good motion throughout, and it was in fact a lung pulse. And so the answer here is atelectasis. there's a lot of atelectasis on the right side, I mean, on the left side. These 4 images are done from a patient who had a right main stem intubation.
There's a lung pulse that is.
Any questions on how I got that?
Yeah, just to go over real quick, so when you are not seeing lung sliding or you're concerned for it, you put it on M mode.
Mm-hmm.
The findings on M mode would be the same as if there was a pneumothorax, correct? But you're looking at the fact that there's a lung pulse when you're on a real-time ultrasound.
No, so, okay, so now let's do the M mode right here, right? Here's your screen. Here's your rib space. Here's your rib space, and you've put the M mode through a region, right? So now, like you put the M mode through here, okay? If I just see lines going like this, you guys see my arrow moving? If I just see straight lines like a barcode, that means that from here all the way down, I'm not seeing any motion.
Yep, we don't see what you're drawing. You're drawing
Oh,
stop
okay.
for some reason.
Okay, so if I just see this,
We see it again now.
right? If I just see that when I'm doing the M mode, that's going to be concerning for a pneumothorax. Highly suspicious for a pneumothorax in that region. But if I'm going around that region and I see, and I say I get to this point and I get to this point, what I'm going to see here is I'm going to see this barcode, but then down here, I'm going to see stuff. You know, whatever, I'm going to see movement. I'm going to see variations. It's going to look like a barcode. I mean, it's going to look like a seashore. It's not going to look like a barcode. And that's telling me that I'm being able to see under this area. If this was a pneumothorax, I would not be able to see under this area.
Essentially, what he's saying is if on that bottom right picture, like that one, if it looks like there's no lung sliding and you're concerned about a pneumo, then you can get M mode right at that point, so you can see if there's any movement at all or not. And if there's no movement at all from the top and the bottom, then it's gonna be a pneumothorax. But if you see that on the top, there's the normal like lateral line, but on the bottom you see like pulsations from the cardiac impulse, like one after another, then you'll know that there is movement there, so that's not a pneumothorax. They'll rule it out.
So cardiac pulsations are always a normal finding, or not lung pulsations? What-
Yeah, so, you know, it's the simple combination. Keep this in mind. This is the simplest way to break it down. Your first question, is there lung sliding, right? You're following the blue protocol. Is there lung sliding? You don't see lung sliding. But either on just being able to see the 3A lines, this is why I really like the 3A lines, or when I do the M mode and I'm seeing motion, I'm seeing activity under that area where there's no lung sliding, that by definition cannot be a pneumothorax. Does that make sense why?
Yeah, makes sense, thanks.
Right, because there's air between the visceral and parietal flora. You should not be able to see artifact or images underneath. You're being able to see cardiac activity, which is like reverberation that's going through all that atelectasis region. So like, you know, like looking at a real life patient, here's the heart, here's the left chest wall, here's the lung that's atelectasis. It's still going against the visceral and parietal flora, but it's not moving. But you're able to see, because there's no air in this region, you're being able to see the artifact of that cardiac activity, which if there was a pneumothorax, you wouldn't be able to see. If this was a pneumothorax and you saw a lung point here, remember the difference between lung point and lung sliding, I mean, lung point and lung pulse. If you put that M mode and you saw that, okay, it's going in and out, and you can slow this down into, you know, like you can take a video or you can put M mode and you can just keep it at that point. And you see that in a certain region, you're seeing lung sliding. And then that same region, being the same area where you had the M mode, is now haziness. That's your lung point, and that is a pneumothorax. So it's very important to differentiate between a lung point and lung sliding. I mean, a lung point and a lung pulse. So last view is, you know, you go to that posterior, those flaps points, and this is where the diagnosis of like pleural effusions and pneumonias really comes in handy. So pneumonia is, you know, generally diagnosis of that's, we make off imaging, right? No one says that, and you guys will hear Dr. Gerber say this all the time, that pneumonia is an imaging finding. You have to see evidence of consolidations. And so chest x-rays have a sensitivity of about like 46 to 77% for diagnosing pneumonia. The gold standard for diagnosing pneumonia is CTs. Ultrasound has been shown to have the same level of sensitivities as CTs from 93 to 100%. And so what you're really looking for is air bronchograms. Air bronchograms are these little hyperechoic lines and dots within the consolidation. It's thought to represent air trapped in small airways. So when you look at the physiology of pneumonia, it's air trapped within these small airways because of fluid, like this gunk and pus being around it. And we're really trying to differentiate. Are you guys able to see this air bronchogram?
Yes, yes.
Right, so that's like what you're trying to practice today when you guys go to that practice session. So what you're trying to differentiate is between static and dynamic air bronchograms. Dynamic air bronchograms, and I don't have this in the slide, but really what you're trying to say is dynamic air bronchograms is pneumonia. Static air bronchograms can be either atelectasis or pneumonia. So once again, dynamic air bronchograms, meaning that is moving, which is what you're seeing in this picture. You see that line kind of moving? That's pneumonia. Versus static, meaning the line does not move, is either atelectasis or pneumonia. What you also see here is what we call hepatization of the lung, which is, so this right here is your diaphragm. And what you're seeing is that this is the liver and this is the lung. And you can kind of see that it looks the same. Because of the severity of the pneumonia, the amount of fluid, it's causing a mirror artifact. You have really bad compressive atelectasis from the pneumonia that it's getting the lung to look like the liver. And that's called hepatization of the lung, and that's classic for pneumonia. So once again, this actually, I think, has a much better picture. So you guys see how that those little ants those little stars on the line are moving? Are you guys able to see that on the right side?
Yep.
Yeah.
So that's what we call a dynamic air bronchogram. That's pneumonia. And on the left side, you see the line again, but it's not moving. And that's static. So that's either pneumonia or atelectasis. And so, in regards to pleural effusions, you could see this. This is your diaphragm. That's your liver. There's pleural fluid. There's different ways to characterize this pleural effusion. You're asking, the question is, am I going to be able to do a thoracentesis in this patient? And I want to be able to make that diagnosis. What if I told you that you could use ultrasound of a pleural effusion to try and get to try and differentiate between a transudative and an exudative effusion? And by the way, this is another finding. If there's a lot of fluid, right? Fluid is ultrasound's best friend. You can go through the rib. Here's your pleural surface. Because everything gets seen better with fluid in between, which is why we put gel on our probes, you can see all the way back to the vertebral space. And this is what we call a V line. All right, so obviously ultrasound guidance. I know some pulmonologists, I'm sure everyone's kind of come across them, that will do thoracentesis without ultrasound. To me, that's almost as scary as trying to do a subclavian without ultrasound. I know Dr. Gerber still does them, but physical exam can be really inaccurate in like 15% of cases. You can cause organ injury. Really, the one that you're concerned about here is a pneumothorax. You can end up putting the pigtail through underneath the diaphragm, above the spleen or into the spleen, right? These are all things that you want to avoid, that you can do with a lung ultrasound. I've seen bad cases where they decided to put in a pigtail for a pneumothorax that was seen on chest x-ray, but they know that there's a pneumothorax there, but they did it in a region where the lung is still touching the pleural surface. So they didn't put the pigtail in the region where there is no lung sliding. They did it in the region where there is lung sliding and caused more pneumothorax that ended up being a cardiac tamponade, because they caused progression by adding a second pneumothorax at the bottom space. Everyone has a different level of confidence in doing this, but really 1.5 centimeters is your minimal space. Or some people will say you want, maybe 5 centimeters. It really varies by how comfortable you are with the ultrasound. And so this is your liver, this is your fluid. You can kind of see this little thing that's moving around. You want to try and use a lower frequency probe. Sometimes for really obese patients, you'll use the higher frequency one. Sorry, the other way around for your lower frequency one, which is your cardiac probe or your phased array probe. You can use the linear probe, but it just can't go that deep. You want to find that diaphragm and make sure you're going above that. You want to identify your surrounding structures. When you see 100 cc's of fluid, seeing this is 100% sensitive for 100 cc's of fluid. And so we talked about characterizing your pleural effusions. You can say small, moderate, large. You want to say, is it heterogeneous, meaning is there like gunk in there, or is it just a clean pocket of black fluid, right? Is it just a pool of fluid sitting around this white stuff? And so if it's heterogeneous, it's probably gunk in it. It could be a hemothorax. It could be a perineumotic effusion. It could be septations. If you see stuff swirling in it, it's probably some exudates. If you see like lines and stuff like a web, it's probably a complicated effusion, specifically an empyema. And I'm sure you guys have all seen this before. You can even add color Doppler to it. So if you see free-flowing fluid versus stuff within there, like this could be a mass, the bottom one, versus if you see color Doppler, there's probably free-flowing fluid. And make sure that, you're not looking at, the left ventricle or a very tortuous aorta that's just kind of going around different regions. This is that classic jellyfish sign. You guys see the jellyfish? That's like a part of your lung just floating in this thing of fluid. Some people call it like plankton, or an octopus sign or a whale sign. Sorry, not a plankton sign, because a plankton sign is something else. You can also see that the lung looks just like the liver. So here's a diaphragm and you're asking, is this the liver or is this the liver? And is this ascites or is this a perineumotic effusion? It's hard to tell, and you can kind of tell between the reason you're getting this like irregular pattern is because the lung is being compressed by all this fluid. And so that's how you know that this is lung, this is liver. Sometimes you might see stuff in there. So I don't know if you guys are able to see, you guys see all this gunk in the fluid? I'll be done in about 5 minutes. There's gunk in the fluid. That's what we call a plankton slime. And you're seeing these like hyperechoic swirls that are, just exacerbated by like cardiac activity or like, the patient taking breaths. That's more suggestive of an exudative effusion. So the plankton sign really refers to that swirling, those echoes within an anechoic space. It's like this gunk between this fluid, and it's really it's moving around, and it's really suggestive of either a hemothorax or a hemoperitoneum. And you can kind of confirm that with a lung ultrasound, with a thoracentesis, but it's just one of those differentials. This is what we call that plankton sign could be either a hemothorax or a pneumonia because it's a perineumotic effusion and there's all this gunk in there, or that the effusion has been sitting there for a while and has caused stuff to build up. This is called hematocrit sign. So you see this layering of red blood cells, and that's really suggestive of a hemothorax. You can see a curtain sign. A curtain sign is generally normal. And the combination of this plus, and you can see this in M mode, is really suggestive of that the lung is at the peripheral base at the costophrenic recess, and this should be normal. This is a normal finding. This is what we talked about, those septations. So this is a pleural effusion with all these lines in there. It's really suggestive of an empyema. I'm sure you guys have all seen this before. You can measure the amount of pleural effusion volume. I don't think it really matters. There's different formulas for it. You can take like, where the lung border is the smallest diameter times the widest dip, and that in someone that's sitting erect, sitting upright, or you can measure the maximum distance between the lung and the posterior chest wall, so like a line going like, in this case, it would be like here. you measure that distance, and you put into this formula. I don't like this one because it underestimates if you have a really large lung cavity. But honestly, I just say small, medium, and large. So once again, this is your blue protocol. Is there lung sliding? If there is lung sliding or not, is it A or B profile? The one I didn't really talk about was this one right here. And this one I don't like as much, this approach. I don't do it as much. But say you see A lines, you don't see B lines, and there is lung sliding. So there's lung sliding, there's A lines. You're trying to differentiate between COPD, pneumonia, or a PE. So their approach to the blue protocol is that you go scan the legs, and if you find a clot there, then this is probably a PE that's causing the shortness of breath. If you don't find a clot, then it's less likely to be a PE and more likely to be a pneumonia or COPD or asthma. And really that differentiates between when you go to your PLAPS points and you go to that posterior points, and if you see gunk over there, then it's pneumonia. If it looks completely normal, like this, then it's more likely COPD or asthma because it's a diagnosis of exclusion. And that's the only part of it that I don't like. And that's where maybe for some people, a stethoscope might still be handy. But if I'm seeing a completely normal lung exam and I'm hearing wheezing and I feel like the patient's tachypneic, and I don't see consolidations of the PLAPS points, I'm going to say it's COPD or asthma. Any questions about the blue protocol? I want to thank Dr. Green for these next set of questions. It shouldn't take that long. So which of the following diagnoses would demonstrate lung sliding? Right, so we talked about, I'm going to jump to the answers here. So we talked about that the absence of lung sliding does not rule out a pneumothorax. So all these diagnoses could not have lung sliding, right? Intubations on the one side, a bronchial occlusion like a mucus plug or a blood clot or a foreign body or a tumor, any process that prevents lung inflammation or lung inflation, like really bad pneumonia or someone that's apneic or severe ARDS, or like, a combination of like that pleural symphysis with that visceral pleural surface are combined, like due to inflammatory regions, or maybe we did it, that could cause lack of lung sliding, and that's not a pneumothorax. Which finding 100% rules out a pneumothorax?
There you go.
Long pulse.
Sorry?
Long pulse.
Yeah, right. And so, a lung point is 100% specific for a pneumothorax. And it represents that edge of the pneumothorax. It's that transition between the absence of lung sliding and the presence of lung sliding. The barcode and stratosphere sign are suggestive of a pneumothorax, similar to the absence of lung sliding. But really your diagnosis that lung pulse definitely rules it out. It's essentially that passive vibration because of the cardiac cycle. You'll usually see in that left hemithorax. And it confirms that there's no air separating that visceral and parietal pleura, right? And once again, if you see it in the appropriate clinical setting, highly suggestive of atelectasis. So in presence of A lines occurs in all the following except what?
Above.
So what's the answer here? Pneumothorax, right? Because you've taken away that, you've put a bunch of air between the visceral and parietal pleura, so you shouldn't see that reverberation artifact. You shouldn't see that finding of A lines because there's no reflection, there's no air between that area anymore. Number 4, true or false? Yep, absolutely. Any questions about that? No, I think we harped that point over. What's more likely if B lines are present on thoracic ultrasound? You guys are superstars now. Which of the following would support the diagnosis of a trapped lung? So it's a bit hard. It's just applying everything that we've learned to try and answer this complex question.
I was thinking D, I don't know. Yes, D.
D is referring to on ultrasound.
A,
So the answer really is all of them, right? If you have a trapped lung and you go in and do a thoracentesis, right? It's not going to change much.
answer was a choice. that
Sorry,
wasn't
guys.
there.
Oh, God.
You guys have any questions?
No.
No.
Thanks, Uday.
Yep, hope that was helpful. So I highly recommend, I know all the residents sitting in the room are going to hate me for this, but I highly recommend that when you guys are, on shift, is that tell your team that when there's a rapid or a code, to tell your residents not to go straight to the rapid or code, to go grab the ultrasound on that floor and bring it to the rapid or code. And so then you force yourself to practice and make a diagnosis and then compare your diagnosis using the blue protocol to the diagnosis that you would make after you get the chest x-ray. And do that again and again and again, and you guys will be superstars at this. And then eventually you'll forget to even ask for the chest x-ray. All right, let's take a 5-minute break and then I'll